No, no, no.
Okay.
I'm
Okay.
I'm Stanley.
Okay.
Okay, guys, we are live now.
Okay.
Excellent. We'll start again. Good morning, or good afternoon, or good evening, whichever part of the world you're connecting from. Thank you for joining our 11th session of the Pediatric Anesthesia Symposium. We have two exciting talks today. The first one will be by Dr. Senthil Packiasabapathy on pediatric eras. This is a talk we managed to get half of it during the take on 2022, but because of the technical challenges, we have to cut it short. So hopefully we can get this done properly today. And people who do know Senthil, Dr. Senthil is an assistant professor of clinical anesthesia in the Indiana University School of Medicine. He's also the faculty at Riley Children's Hospital in Indianapolis. His interests are in pediatric anesthesia, transplant anesthesia. One of the key reasons we wanted Senthil to give this talk is that he has done a lot of research in this area, and so we can get a first-hand information of what pediatric eras is all about. So we are fortunate to have Senthil to join us for this talk. And our second talk will be on laparoscopic surgeries and robotic surgeries by Dr. Sanjay Prabhu. He's not a new name for people who follow our symposium series. He's done a lot of talks for this series. And Dr. Sanjay Prabhu is a pediatric anesthesiologist at the Apollo Children's Hospital, and his interests are in regional pain management and medical education. And Senthil's talk we already recorded for the take on, so I'm going to go ahead and play that. If that is okay with you, Senthil?
Yes, that'd be great.
Okay.
Thank you. Pediatric practice. I do not have any conflicts of interests to disclose today. Moving on to objectives, we will define enhanced recovery after surgery and get into enhanced recovery protocols for pediatric anesthesia. We will discuss the role of multimodal analgesia in enhanced recovery protocols, and we'll also get into the specifics of multimodal analgesia that we use here at our center for pectus excavatum and posterior spine fusion surgeries. Enhanced recovery after surgery is a multimodal interdisciplinary system of perioperative care achieved by attenuating the body's profound stress response to surgery. This helps us achieve early recovery after major surgeries. The gentleman that we see on this picture here is Dr. Henrik Kælet. He is a Danish GI surgeon, widely regarded as a father of ERAS. He has done a lot of work on this area. The initial report by Kælet and Dr. Bardram et al. Was on a small cohort of adults undergoing colonic resection, followed by a larger cohort of adults undergoing sigmoidectomy, where they were able to achieve a length of stay as short as 2 days. Stress response to surgery includes neuroendocrine stress response, which has two components, neural and humoral, involving the hypothalamic, pituitary, and adrenal axis. Metabolic stress response to surgery involves hyperglycemia, gluconeogenesis, glycogenolysis, and protein muscle breakdown, basically a catabolic state. Immunological stress response leads to a pro-inflammatory state, leading to activation of cellular and humoral immune responses. And the hematological response results in a prothrombotic state. And last but not the least, major surgery could cause undue emotional, psychological, and socioeconomic stress, which could be burdensome and expensive, both for the patient, family, as well as the healthcare system. ERAS protocols are designed to address these stress responses to major surgeries. These are elaborate protocols with preoperative, intraoperative, and postoperative components. In the subsequent slides, we will get into the details of these and also understand the role played by the anesthesiologist to enable these protocols. Moving on to multimodal analgesia, which is a key component of any ERAS protocols. This is defined as a systemic administration of 2 or more analgesic medications that are strategically combined to block pain perception at multiple locations in the peripheral or central nervous system. They usually have synergistic or supraadditive effect to achieve very good efficacy of analgesia while also minimizing the side effect associated with the use of high dose of one single medication. And multimodal analgesia helps us to move away from opioids as the primary or the sole analgesic agents. Pain after surgery is a major patient dissatisfier. As we could see in this flow diagram, pain is a major contributor towards a number of stress responses that delay recovery after surgery. Multimodal analgesia, on the other hand, addresses a number of these targets through ERAS to overcome many of these stress responses. It decreases pain and suffering, decreasing the emotional stress. It enables early ambulation, decreases opioid requirements, facilitates early bowel movement, and decreases the length of hospital stay, minimizing the socioeconomic stresses. One of the primary tenets of multimodal analgesia is to have opioids as the last resort to manage breakthrough pain. We all know that opioid use could be associated with a number of short-term adverse effects, including the life-threatening respiratory depression. There is a large body of evidence that suggests that ERAS protocols limit intraoperative and postoperative opioid use. Opioid use can also, in the long term, contribute to opioid-induced hyperalgesia, tolerance, and early dependence, especially in teenagers. Currently, there is no definitive evidence supporting the impact of ERAS programs on chronic opioid use. However, the greater weight of evidence suggests that chronic post-surgical pain could be minimized or prevented by aggressive multimodal analgesia after surgery. This figure shows the classical components of a multimodal analgesia. The base is formed by regional and local analgesic agents like epidural infusion of local anesthetic in whatever cases it is possible. Upon this is the scheduled administration of systemic non-opioid analgesics like acetaminophen, NSAIDs, gabapentinoids, and muscle relaxers. Systemic opioids are reserved for use as needed for management of breakthrough pain. Though primarily introduced in adult population and slowly adapted into pediatric practice, pediatric ERAS protocols are exploding of late with an increasing number of publications. Knowledge of ERAS has even been applied in ambulatory daycare surgeries. Here are a few examples of an increasing volume of pediatric ERAS publications. The ERAS Society has also come with a number of guidelines specific to various pediatric surgeries. I work at Riley Children's Hospital. This is a tertiary academic hospital affiliated to Indiana University School of Medicine. Here at Riley, we have ERAS protocols for laparotomies on children above 1 year of age, laparoscopic colectomies, pectus repairs, posterior spine fusion for idiopathic scoliosis and neuromuscular scoliosis, major urology, reconstructive procedures, and other major orthopedic surgeries. Posterior spine fusion for scoliosis and Nussbaum repair for pectus are some of the most painful surgeries. So I've chosen these surgeries for our discussion today. This is a paper we published where we evaluated outcomes of enhanced recovery protocol after posterior spine fusion in patients with idiopathic scoliosis. We compared 60 patients who got the surgery after implementation of the ERAS protocol to matched historical cohort of 60 patients who received the surgery prior to the implementation of the protocol. The vertical orange line here denotes the date when the enhanced recovery protocol was introduced, and this was before and this was after that. This is a chart that shows the length of hospital stay, and we could see the median length of stay was 3 days before the protocol was implemented, and after the protocol, it dropped down to 2 days. And we are able to send a few patients home even on day 1 after thoracolumbar fusion for idiopathic scoliosis. This is a comparison of opioid utilization before and after the enhanced recovery protocol was implemented. We were able to find a significant decrease in opioid use with enhanced recovery protocol. Moving on to the specifics of analgesia that we use for pectus and posterior spine fusion. In the preoperative period, the most important thing is to manage expectations. Psychological preparation of patient and family is very important. We need to help them understand the natural course of recovery after surgery and also set expectations right in terms of postoperative pain. This helps to some extent to allay baseline anxiety. Apart from psychological preparation, the preemptive analgesic regimen includes acetaminophen. We used to administer pregabalin. We have kind of moved away from this practice after the recent meta-analysis that discredited the use of gabapentinoids for perioperative analgesia. Patients also receive methadone in the preoperative period. Methadone is a very unique opioid with NMDA blocking properties. It is very long-acting and is rightly called the opioid-sparing opioid. It definitely helps to minimize the use of other short-acting opioids that are habit-forming. Intraoperatively, pectus patients receive epidural catheter. Posterior spine fusion do not receive any kind of regional analgesia. All of these patients receive ketamine infusion and steroids are administered intra-op. Opioids are used as needed, and NSAIDs like ketorolac are also administered. In the postoperative period, all patients receive NSAIDs, either ketamine or ibuprofen and acetaminophen. They also receive antispasmodics, including methocarbamol and diazepam. Opioids are used as needed. Patients and the families receive a thorough education of the pain medications that they're going to go home with. This is the medication calendar that the family would receive during the time of discharge. It is a color-coded list of all the medications that they are going to go home with the specific times of administration, which kind of makes it easy for them to keep up with the pain management after they go home. Apart from minor differences in the choice of regional, the enhanced recovery protocols and the multimodal analgesia for pectus bar repair and posterior spine fusion are very much similar. The choice of regional for pectus procedures at our institution is the thoracic epidural catheter. Other centers also use paravertebral catheters. The other options include intercostal nerve blocks, PEX 1-2 blocks, and serratus plane blocks. Some surgeons that perform ravage procedure use exparel for wound infiltration. A recent addition for NUSBAR pectus repair is the cryoablation of intercostal nerves done under direct visualization of thoracoscopy in the OR. These patients usually do not require a thoracic epidural, although it takes almost 12 to 24 hours for the numbness from the cryoablation to set in. These patients receive a multimodal analgesia to keep them covered for the first 24 hours, and they are usually discharged home on post-op day 1. For thoracic epidural, in pectus repairs, we need a dermatomal coverage of T4 to T6, and so the catheter is placed at T4-5 or T5-6 interspace. We run a continuous infusion of ropivacaine 0.2% at a dose of 0.4 to 0.5 milligrams per kilograms per hour. Additives like opioids or clonidine can be used, but we do not use any additives, and the catheter stays in place for 2 to 3 post-op days. A few pros and cons of thoracic epidural analgesia. It obviously provides superior analgesia, minimizing opioid requirement. It also decreases morbidity and mortality through a number of its physiological effects. On the con side, we have arterial hypotension, pruritus if opioids are used as additives, urinary retention, which is usually a very minor problem with the thoracic level of epidural, motor blockade, technical failures, epidural hematoma, abscess, and neurological injury. The risk of epidural hematoma is about 1 in 168,000, infection 1 in 145,000. Similarly, neurological injury, persistent or transient, is also extremely rare, in the order of 1 in 200,000. And most of this is from the OBG literature, and the chances of complications with a thoracic epidural in an otherwise healthy teenager is even lower. Here is a table that details the adjuvant medications used in our multimodal regimen, the ones that are scheduled and the ones that are used as required PRN. Gabapentinoids. Gabapentin and pregabalin are primarily anticonvulsants. They act as neuromodulators by inhibiting presynaptic voltage-gated calcium channels in dorsal root ganglion and spinal cord, thereby decreasing the release of excitatory neurotransmitters. They can cause sedation and respiratory depression. Studies have shown significant opioid-sparing effect of gabapentinoids. However, a recent meta-analysis of 281 trials that included almost 25,000 participants showed no clinically significant analgesic effect for perioperative use of gabapentinoids. Methadone is a long-acting synthetic opioid with an elimination half-life of 24 to 36 hours. It primarily acts as a mu-opioid agonist, but also has some kappa and delta activity, along with NMDA blocking and SNRI properties. It has minimal tolerance, minimal dependence, does not form habits like the other short-acting opioids, and also does not cause opioid-induced hyperalgesia. We dose it at 0.1 milligrams per kilogram and max it up at 5 milligrams. It is dosed every 12 hours on post-op days 0 and 1, sometimes day 2 as well. Adverse effects include sedation, respiratory depression, nausea, vomiting. QT prolongation is a very unique side effect of methadone and usually is a problem only with long-standing use of methadone as in opioid use disorders. And methadone has shown significant opioid-sparing property in multiple studies. These are two large meta-analyses that studied the use of methadone in the intraoperative period. And they have shown significant opioid sparing with the use of intraoperative methadone, along with significantly improved post-op pain scores and better patient satisfaction. Moving on to NSAIDs and acetaminophen. NSAIDs are COX-1 and 2 inhibitors that decrease prostaglandin synthesis and prevent peripheral sensitization. The therapeutic effects are from COX-2 inhibition. The side effects like platelet inhibition, bleeding, and gastric ulcers are from COX-1 inhibition. To minimize the side effects, we could use COX-2 selective blockers, celecoxib, but these are also associated with an increased risk of ischemic heart disease and stroke in adults with prolonged use. Acetaminophen is a CNS selective COX-3 inhibitor that acts as a central pain modulator. A combination of acetaminophen and NSAIDs is considered to be supraadditive or synergistic. Muscle spasms after pectus and posterior spine fusion are a major contributor to pain due to the mechanical distraction that's used as part of the surgery. Muscle relaxers including metocarbamol, cyclobenzaprine, and tizanidine help with the spasm. The most commonly used agent is metocarbamol at a dose of 10 milligrams per kilogram. It is available as IV and oral formulations. However, the IV preparation needs to be used cautiously in underlying renal disease. There is only a level 2 evidence that supports the analgesic efficacy of these agents. The mechanism of action is unknown, and it is thought that these medications act at the level of spinal motor neurons. They could also have some CNS effects, causing mild sedation. The other class of medications that is used as antispasmodics is benzodiazepines. These are GABA agonists. They also have anxiolytic and sedative properties. The most commonly used medication is diazepam at a dose of 0.1 milligram per kilogram. Other adjuvants used as part of enhanced recovery protocol include NMDA antagonist, ketamine, alpha-2 agonists such as clonidine, dexmedetomidine. Some centers use IV lidocaine infusion. Corticosteroids were very useful in nausea vomiting prevention. They also have some analgesic properties. Ondansetron is used for nausea vomiting prevention, and an aggressive bowel regimen is always a part of any enhanced recovery protocol to accelerate recovery after surgery. As we already discussed, IV and oral opiates are only used as last resort as PRN medications as needed for management of breakthrough pain. Maximal pain after surgery is on days 0 to 3. This is when we need a good epidural coverage, after which the epidural can come out. A baseline regimen of scheduled antispasmodics along with PRN Valium, scheduled NSAIDs, and acetaminophen provide a good pain coverage during this period. Methadone is also administered on day 0 to 1. This facilitates out-of-bed ambulation, physical therapy, and incentive spirometry on day 1. After this, as-needed oxycodone is added to the schedule to bridge the epidural removal. This is a paper showing the superiority of methadone-based multimodal analgesia in pectus surgeries, and to the right is our local data on patients receiving pectus repair. The orange lines here is after the enhanced recovery protocol was introduced. You could see that the PRN as well as the total opioid use was significantly decreased after the enhanced recovery protocol with the multimodal analgesic regimens were introduced. Given ERAS is a multidisciplinary system, there could be a number of barriers and challenges in successful implementation, including stakeholder buy-in and integration into electronic health record system. It's very important to engage all team members, including surgeons and nursing staff, to plan and successfully execute ERAS protocols. Education is essential for all healthcare staff involved in pre-op, intra-op, and post-op care, including pain service, pharmacy, and nursing staff. We need a lot more robust randomized control trials to generate good quality evidence to support our practice. Having said that, ERAS is still a work in progress that demands continuous process improvement. It's important that we recognize change is hard and implementation is only the beginning. We need to keep identifying and incorporating best practices to improve our patient outcomes. These are some of my references. Thank you all for your time and attention, and thank you very much for this opportunity. Have a nice day.
That was excellent. I wasn't watching the YouTube comment section, so I don't know whether we have any comments on that or anybody has any questions.
There isn't any, Jody.
Okay.
Yeah.
Thank you.
So I see a question on the chat. Why do we not use regional analgesia after scoliosis surgery? That's a great question. Previously, we used to do intrathecal morphine before scoliosis surgeries. In fact, the surgeons did it like when the patient is on the field. we kind of got away from this practice because we were already discharging patients home on day 2 and some of them on even day 1. And this only added to problems like itching and nausea, vomiting, and the surgeon did not want it. So that's kind of the reason, because the surgeon was kind of happy with the other parts of the multimodal protocol.
I think we are probably one step behind. We are not into ERAS yet. We don't have access to IV methadone, which limits some of our challenges in introducing in the first 24 hours. So we are still on, we do still do spinal opioids for our scoliosis patient. If the lumbar curve is not significant, and we do it ourselves in the beginning of the case, and we administer 5 mg per kilo to a max of 300 microgram. If the curve is significant, or if the surgeon is anyway exposing the lumbar pedicles, and then they can administer at the end of the case. So we have both options available, and it works very well for the first 24 hours to minimize the number of button pushes for PCA. And then they can go on oral regime the next day. We haven't yet got on the methadone protocol yet. It's still in discussion after a talk by the other Senthil to our department. We're still exploring those options. Thanks.
Terry, did you say you use morphine in intrathecal?
Intrathecal morphine, yeah. It's a preservative-free one.
And what's the dose? 5 milligrams, 5 micrograms per
5 micrograms per kilo to a max of 300 mics. 300 mics, yeah. Yeah, that's our protocol. Dr. Paliwal has asked about erector spinae plane block. I have done it a few times in scoliosis. I find it very challenging in the concave side. In the convex side, obviously, you can see the transverse process and the ribs coming up, and you can identify the plane. But in the concave side, the TPs are quite rotated, and they're quite, in fact, they're on facing more medially or inwards. So it's difficult to angulate the needle to get to the transverse plane, to the transverse process. That's my challenge. I don't know if others have any experience. In scoliosis patient, in a straightforward, like a lumbar discectomy, it's a different matter because the processes are quite. Yeah, that's my experience. Is anybody, Sanjay or Senthil?
No, the incision for scoliosis is quite long actually. So that's why we do have trouble. Even if we do an epidural, it may not cover the entire incision. And any sort of block like erector spinae, I'm not sure if it will distribute to cover the entire incision of the scoliosis.
Yeah, it has to be done in a 4-segment, 4-quadrant sort of. So you divide the spine into upper and lower half, and you do 2 injections, one at the top and 2 in the bottom, in the middle of your division. That's how people have done it.
What we have done in our institution is we ask the surgeon to place the epidural at 2 levels, so that it will cover the entire incision. And we run a common infusion we run a separate infusion for each of the catheter.
Yeah, that has been described as well. Yeah, double epidural. Sure.
Like in adults, it's seen that the contrast studies, and they have shown that with the single injection of the spinae, you get probably even with 20 ms, you only get like 4 or 5 segments. But in pediatrics, are there any study on the volume used and the spread of erector spinae? Anything you're aware of?
I haven't specifically looked at it, and there's probably out there. We have some of the limitation is the size of this patient. Very often, in an idiopathic spine, it's probably fine. There will be adequate volume he can give. In smaller children, you will be limited by the volume because of their size.
Yep. But scoliosis surgery is usually done in patients who have reached a stage where you're not expecting much.
Yeah, no, I mean, there's two populations. One is a adolescent idiopathic spine, but we also have significant volume of complex, the kids with the myopathies and Duchenne, and they are all what do you call secondary scoliosis, where it is very challenging. They are a completely different population. Very often they need an ICU admission afterwards, massive transfusions, post-operative respiratory support. They might be already on BiPAP, they may be already tracheostomized. So that's completely different population. Again, in that population, introducing ESP probably will not be a worthwhile exercise because they're likely to be ventilated afterwards anyway. And Dr. Vidya has asked about intraop ES plane block. Obviously, they're opening up those muscles and they're stripping the muscles away. My spine surgeon, when we talked about it in the first set, well, I'm cutting all those nerves anyway. Why you bother putting local anesthetic there? He said. It does. I mean, it probably. I don't think it will be effective because they're going to strip it away. But if you do it before the incision, there is adequate time for it to distribute and get absorbed into the tissue planes.
Well, even then, I think it would be pretty short acting, and we'd like at least like a day or two of coverage. And in that case, we need a catheter. And the surgeons seem pretty anxious about like chance of infection with an indwelling catheter with a spine fusion.
Yeah. Yeah, the other challenge is also some people talked about using dexmedetomidine. In fact, the adult center here, Ki-Jin Chen, he's a regional anesthesiologist. He's a well-published guy from Toronto Western Hospital and regional anesthesia. He does use dexmedetomidine as a for the spine surgeries where he does the spine plane block. However, the neuro monitoring protocols are very different between our two hospitals. The Children's Hospital, we monitor both not only sensory, but also we do the MEPs, motor evok potentials. And a single shot of dexmedetomidine can completely abolish your motor signals very easily. And that confounds the neuro monitoring. So we stayed away from using, even if you are doing erectospinal blocks, we avoid adding dexmedetomidine, which we commonly add to other plane blocks. But in this surgery, we will avoid because of the neuro monitoring protocols.
Senthil, can I ask a question?
Yeah. Sir.
You had mentioned briefly in your talk about moving away from gabapentinoids.
Yeah.
Is that some new study saying that it's not effective, or it's
I think it was a meta-analysis in ANA, I think, early last year or 2020, sometime like that. It was like a really huge study. It was like they kind of did not find any significant opioid sparing on that meta-analysis. And in fact, the adverse effects were like overwhelming, and it was not worth using. That was kind of their conclusion. So after that, it was kind of an institutional-wide change in at least prophylactic administration of gabapentinoids.
Is this in specific relation to spinal surgery, like scoliosis, or in general for all surgery?
No, in general, perioperative.
Oh, okay.
Use. Yeah.
Even in adults, even in adults, that's one of the problems with adults was sedation and falls following use of pregabalin. Yeah, but what anecdotally we have actually come to know from our acute team after withdrawal of pregabalin from so we have the low limb protocols for orthoplasties, and they think the pain control was better along with pregabalin as compared to after taking it off. But that's just aside.
Yeah, I did look at in spine population. We did publish it in for scoliosis patients. A single dose gabapentin preoperative administration 45 minutes before the surgery, did not make a difference in their post-op opioid consumption.
Rajesh Shah has actually mentioned that's on the YouTube thing. He says he does do erector spinase for spine and have found good results. Pain scores almost VAS of 1 or 2.
Yeah, and Dr. Paliwal has mentioned, as per reports, MEPs are well maintained after Dexmed. It's as I said, I mean, we also gone through this set of conflicting evidences. In fact, our neuromonitoring protocol, they give us a talk to all the anesthesiologists every 6 months for the new residents and fellows. And he shows this pre-Dexmed and post-Dexmed MEP signals. It's pretty dramatic. When you see it happening in front of your eyes, you can't say that it doesn't affect it. So, and there are papers out there as well that shows the drop in MEPs with the use of dexmedetomidine. I don't know, Senthil, you had any experience with use of dexmedetomidine and the motor evok potential?
Yeah, neuromonitoring people here also discourages strongly against use of dexmedetomidine. I've seen a few papers that are kind of that support their argument, and there are a few papers that are kind of equivocal, but we have to go by what they say, so we'll just avoid it.
Yeah. Are MEPs affected by IV Dexmed? Yes, that's again. I would maybe in the next session I would bring some evidences from our neuromonitoring. They as soon as they will show us when we gave the Dexmed. They said see the signals. Shiv.
You're muted, Shiv.
We could get our Nitin Manohar and those guys also talking about, they do a lot of neuromonitoring.
Yeah.
And that's I think we can actually have a session. We were actually planning a session anyway. Yeah. So we could combine the adult and pediatric neuromonitoring.
Yeah.
And I think that'll be a great session to look at.
Senthil, we don't have IV methocarbamol in India. So,
okay.
Would you recommend sort of a regular administration of oral methocarbamol for post-spinal scoliosis patients?
Absolutely. As soon as they are able to take oral, which usually is on day 1, these patients could be oralized, and oral methocarbamol probably at a dose of 15 milligrams per kilogram every 8 hours.
Okay.
It's amazing. Yeah.
Can I ask about the dose of methadone? You said the half-life is around 36 hours, but you still give them every 12 hourly?
Yeah, so we found that the half-life is more kind of context sensitive in terms of the dose that we use. So when we give it at a dose of like 20 milligrams of more per dose, it actually acts for 24 to 36 hours. At a smaller dose, like 5 milligrams, it easily gets compartmentalized, and this minimizes your blood drug concentration. So it is kind of safe to administer it every 12 hours. We kind of max it out at 5 milligrams. So per kg dose is 0.1 per kilogram per dose, twice daily.
Yeah. I mean, the methadone is easily available to us, but it's mainly used by the IV drug abusers for whom they are trying to wean them off. And some of them are quite, one of the things I have noticed with anesthesia in these patients is that if you leave them spontaneously breathing, their respiratory rate is like they're breathing big volumes at 4 to 6 breaths per minute. Do you actually, I mean, you say you do give them pre-op as well.
Yeah.
Do you see any effect on, I don't know, well, obviously you may not be using spontaneous ventilation in these cases, but in any other cases, do you see effect on
Yeah, like you said, yeah, we only use that. I personally use it in like big surgeries like X-labs and pretty long surgeries, so that when they wake up, they're pretty normal. And in the intra period, they are paralyzed and ventilated, so it doesn't really matter for us.
So no
And,
effect on the post-operative period when they wake up. You don't see that.
not really, not really. I mean, even when they wake up, they at least require like one dose of some other long-acting opiates in many cases, just to keep them covered.
Yeah, something I would actually like to look into for adults as well. I think this will be great.
Yeah, there could be like occasionally a few patients who are extremely sedated with methadone. In those patients, we cut down a dose or two, or even like stop methadone. So there is this cytochrome CYP2B6, which could be variable in the population, and some people metabolize it much slower, which could cause increased incidence of side effects from methadone.
Yeah, when I was doing my pain fellowship in Australia, I think we were made to believe that methadone is a very dangerous drug with very variable pharmacokinetics and pharmacodynamics. So it's generally not used in opioid naive patients. That's the impression I got when I did my fellowship 10 years ago. So maybe things have changed. So yeah. Maybe is it coming into practice as an acute pain analgesic? Maybe.
Yeah. Many centers are starting to use methadone for the perioperative period.
Mm-hmm.
Yes, and I think there's also like a lot of literature that's coming in supporting the use of methadone for acute pain.
Mm-hmm.
Yeah, we use oral oxycodone for patients, so maybe methadone could be another of the alternatives.
Yeah, the oxycodone has sort of now is considered the most abusive drug in the market. So people are trying to move, find anything that they're falling back into using regular opioids like morphine. Yep. People where you would have prescribed them to go home on oxycodone. Now we are going back on morphine. That way, it's less additive potential. And then I think Senthil mentioned about the use of cryoablation. That's the one thing we used to do thoracic epidural for this, and it used to be very challenging. Even though a perfectly working thoracic epidural, the kids, adults and teenagers wake up and they scream in pain. You can demonstrate analgesia, numbness, but they still are completely uncomfortable in these practice cases. And what has changed for us is introduction of serratus plain block and the cryoablation. That's what we do now. They get an intra cryoablation at the end of the surgery, and we do a pre-incision serratus plain block, and they go on PCA plus. We stop doing epidurals for those practice patients now. Senthil is posted
directly move to the next
talk. We can move on to our next talk. We need Sanjay. Sanjay has the permission to share his screen.
Yes, all of you have got permission to share the screen.
Thanks.
Can you see my screen?
Yes, please.
Okay. Okay, good evening to everyone. So my topic is anesthesia for pediatric laparoscopic, and briefly about robotic surgery as well. So I'm certainly not an expert in robotic surgery, but I have done a few patients. So based on my experience, I'll try and share whatever I know about robotics. In our hospital, I think we do predominantly robotic pediatric urology as robotic surgeries and some ENT surgeries. So so like in other patients, I think there's a lot of common implications with laparoscopic surgeries. Maybe there are some differences in children. So I'll start off with a hypothetical case. I think most of the pediatric anesthetists would have seen this situation. So we have a 6-month-old child who's coming for a laparoscopic herniatomy. After insufflation of CO2, the child tends to desaturate. So I just leave the questions open to the people who are listening. So as to what you will check, how you will respond, what are the likely causes in this situation, and how will you manage the situation? Okay, so I'll go through some differences between pediatric and adult patients with a specific emphasis on neonates and a few points about thoracoscopy. And regarding robotic, how is it different and what are the special considerations? So yeah, we need to realize that minimally invasive surgery does not mean minimally invasive anesthesia. So we do have definitely some implications which we need to be aware. Coming to some anatomical differences. Yeah, so we all know that children are small adults. So everything is smaller. The abdominal cavity is smaller. So we need smaller instruments, smaller ports. We will have less space to work around the child with all the gadgets and the laparoscopic trolley. And they do have a sort of the abdominal muscle is less developed, so the abdominal wall is more pliable. And second is the cavity is quite small. So yeah, the risk of injury to structures while doing laparoscopy is probably higher. So you need to have a lower threshold and higher vigilance when you sort of do small children. And the smaller the child, higher the risk is. And we have some abdominal organs which are larger in children. Typically, the liver is below the rib cage. So just need to be careful that they don't injure the liver. And all patients are made to pass urine. We do this as a deliberate protocol before they are wheeled into OR. They should have the bladder emptied because they could easily injure the bladder when you do the ports. The intraabdominal fat content is less. So basically, this means that the CO2 insufflation, which we do, the fats may not sort of absorb the CO2. So there's a higher risk of there's an increased hypercapnia seen in small children. Yeah, so some of the reasons why they tend to absorb more CO2 compared to an adult patient is they have a relatively larger surface area in comparison to the body weight, and the distance between the capillaries and peritoneum is smaller. So this basically leads to a higher CO2 absorption. And because of the higher vagal tone, some children do have a risk of bradycardia during the insertion or when you inflate the abdomen. So that's why in children, it's recommended that the flow is kept low in initial stages and slowly increased, because sudden inflation of the abdomen can provoke a bradycardia, and some situations can also lead to quite significant bradycardia leading to asystole. Regarding the physiological changes, I don't think there's anything much different compared to adult patients. But I think the respiratory changes probably sort of have the most significance, given that they already have a higher closing volume, a smaller FRC. So when you sort of increase the intra-abdominal pressure, this can manifest in a more significant way. And the result is that the risk of hypoxemia is higher in small children. So that's a picture showing that what happens to the lung when you have a normal procedure as opposed to a capnoperitoneum. And when you add some head-down position, it becomes even worse. So there are some changes which can happen when you give a head-down position. Regarding the CO2, what we inflate, not many of us watch this when we do adult patients, but I think when we do pediatrics, I think it's important to watch what the surgeon sets, what the surgeon asks for. So for small children less than 1 year of age, we recommend that the intra-abdominal pressure is kept between 6 and 8 and not more than 8. And even in older children, they recommend that we keep pressures less than 12. And 15 is probably the cutoff because beyond which the risk of organ perfusion becomes, organ perfusion is compromised. So that can lead to changes in the cardiac output. There could be increase in the cardiac, the systemic vascular resistance. The cardiac output can drop. The venous return can decrease. So all this can lead to hypotension. Flow rates, again, as I said earlier, try and keep the flow rates low. Higher flow rates, one is it can cause a quick pneumoperitoneum, which can cause bradycardia. And when we use these gases, they are dry gases. So when you use high flows, it also increase the risk of hypothermia in small children. And the volume, again, try and keep them depending on the patient's size. So that's a graph which basically depicts the amount of CO2 flow you keep, which is clearly lower in smaller children. And same with the pressures as well. The pressures are lower with smaller children and slowly increases as the child ages. Regarding anesthesia, I don't think there's any specific technique recommended, but there are certain things we need to be aware. One is the airway. So we've stopped using uncuffed tubes anyway in small children. So for people who still use uncuffed tubes, it may not be the best option. Regarding laryngeal mask airway, again, I personally wouldn't recommend it unless you have a very quick surgeon who can do it within a few minutes, less than 10 minutes. And in smaller children, do have a lower threshold for going for an endotracheal tube. So it's safer, and you can control the respiratory mechanics much better with an endotracheal tube in place. Yeah, decompression of the stomach and bladder is quite important. Hydration and temperature, again, not as much implications as an open laparotomy. But you still need to be aware that temperature can drop with the high gas flows. And hydration, they may not require much fluids like an open laparotomy. So you just need to be aware of that. And there are certain steps in the procedure where you need to be more vigilant. Typically, the needle insertion, CO2 insufflation, and when there is a change in position. Regarding ventilation, so so there is a choice between using volume control and pressure control. So I think each one is different. So some people, they go for a volume control ventilation. But if you have a anesthetic machine which can provide pressure control ventilation with volume guarantee, that would be a good option. Having said that, you need to keep a track of the airway pressures and the peak inspiratory pressures. Because when there is a drop in the peak inspiratory pressures, it could mean that there is a leak somewhere. The entire CO2 which we monitor may not accurately reflect what is seen, what is arterial CO2. So you need to be aware that it could be higher, or that there could be a large discrepancy between the arterial and the enteral CO2. So quite often we find that in children, the risk of capnoperitoneum causing high CO2 absorption is more significant. So you might have to increase the minute ventilation even up to 50 to 100% of what the initial setting was. And in patients where you have a steep head-down position, you might have to increase the PEEP and increase the FiO2 to prevent hypoxemia. And in a situation where you think the CO2 is gradually creeping up, the oxygen saturation is not holding, don't hesitate to tell the surgeon to decrease the pressure in the abdomen or to intermittently release the pneumoperitoneum. And if you think, and when you've set a volume control ventilation, if you think the peak inspiratory pressure has gone beyond 50% of the baseline, that's one indication where you might have to tell the surgeon to decrease the pressure. So in terms of benefits, clearly the pain is much less with the laparoscopic surgery. And for some reason, children don't sort of complain of the shoulder tip pain as much as adult patients. But still, a multimodal technique is useful, as Senthil had said earlier, as part of ERAS. Risk of PONV is higher, and there are some complications which can be quite dramatic. Typically, one is the venous air embolism during CO2 insufflation. So this happened to me one morning, 6 a.m. in the morning. It's a 2-year-old child shifted from ICU with empyema. The surgeon is planning for a watch thoracoscopy. So there's no one around. it's always scary to do a case first thing in the morning when there's not much support. So did a normal pre-oxygenation. Post-intubation, child had a bradycardia and very quickly went into asystole. So started CPR, suctioned the tube, withdrawn the tube a little bit, and finally we got the child back. But it was really scary. I mean, within no time, the child went in for a brady and asystole. So what could have happened? Anyway, so thoracoscopy or VATS procedure is probably a little more challenging in small children compared to laparoscopy. One, because they have a diseased lung. Okay, so you could potentially be working only with one lung, and many children less than 1 year of age, they don't tolerate one lung ventilation, and it's again, we don't have the necessary equipment to achieve one lung ventilation in very small children, and they don't tolerate the lateral ligamentous position as well as in adult patients. One is because they have a very compliant chest wall. So when you put them on the lateral position, and some surgeons, they place a roll under the shoulders or the mid-thorax. So the dependent hemithorax gets compressed. So, there is atelectasis. So there is perfusion in the dependent zone, but there is decreased ventilation as well because of the compression from external compression. So lateral decubitus is not well tolerated in small children. So just be aware of that. And thoracoscopy, the recommendations are you keep the pressures lesser than for intra-abdominal procedures for the reason that, again, hypercarbia occurs with these patients. They have a diseased lung. So the complications can be higher in these patients. And many times we've seen that they might require a period of hyperventilation for probably 5 to 10 minutes after the procedure is done to wash out all the CO2 which is accumulated. Otherwise, the children don't wake up. So yeah, one is you need to hyperventilate post-procedure. They might need some intratubal suctioning because they could have some blood clots or mucus plugs coming from the endotracheal tube or occluding the tube. And any thoracoscopic procedure, just be aware that you need a good venous access. One is they are handling things very close to the heart. The VATS for empyema, they tend to bleed a lot. So make sure that you have adequate venous access. So this child, clearly the cause was an endobronchial intubation. This child came with a right-sided diseased lung. So obviously when I intubated the child, probably I went too far in. So it was clearly endobronchial intubation into a lung which was diseased. So basically the child completely stopped having any kind of ventilation. When it comes to doing neonatal surgery for laparoscopy or thoracoscopic surgery, clearly the margin of safety is much lower compared to older children because of the anatomy and physiology. Secondly, they do have a higher risk of venous air embolism. One is because they have patent umbilical veins and ductus venosus. So in small children, the surgeons try and avoid a subumbilical port, or they do it under vision, because there have been many instances where they've cannulated, they've started the insufflation, and they found that patient had a cardiac arrest. So possibly it was venous air going into the umbilical vein. And when you do give a head-on position for these children, the intratracheal pressure tends to increase. So this tends to be higher in small children who have a risk of intraventricular hemorrhage. So in preemies, it is considered a relative contraindication to do a laparoscopy with a head-on position, or use too higher pressures in the abdomen. And obviously, all these effects are more common during thoracoscopy and proportional to the pressure and flow rates and the duration of insufflation. So, yeah, one other question which we might have is, children with VP shunts, do they have a contraindication for laparoscopy? Not really, but just make sure that the shunt is working, because what happens is when you do a laparoscopic insufflation of CO2, we have an increase in the intracranial pressure. So for a patient who has a normally working VP shunt, the pressure gets relieved by the working VP shunt, where the CSF tends to come into the abdomen. But if it is not working you could potentially risk a increase in the intraocular pressure. So, and the second thing is when you have a laparoscopic surgery which involves opening the bowel, or a laparoscopic urological surgery which requires opening the urinary system, there is a potential risk of contamination of the VP shunt and subsequent meningitis if that happens. Now, coming to robotic surgery, so it is I would say it's a glorified form of laparoscopic surgery. It's more it's more useful for the surgeon in terms of more precise movements. Okay, so and it's recommended for surgeries which are inaccessible, typically in pelvic surgeries. It's a 3D visualization compared to laparoscopy, which is 2D. And the degrees of freedom in a robotic surgery is much higher compared to a laparoscopic surgery. So they say they have some 7 degrees of freedom. So yeah, it is used in surgeries where there's more skill required, more finer movements required, providing the patients can afford it. Regarding the theater setup, you require a larger theater because the robo occupies significant space. You need to plan the position of the table, the anesthetic machine, how are you going to sort of place the robo and so on. So that is a picture in our theater showing the robo. So you can see the surgeons there with the patients lying there. That's the laparoscopic screen there. That one is the robo. And here you have the anesthetic machine. And in the next picture, you can see that this is the primary surgeon who is not with the patient, but who is sitting in the console and operating the robo. So he sort of dictates how the surgery is done. So the limitations of robotic surgery is obviously it is expensive. You need a lot of equipment. And docking basically means when the robo is set up on the patient, and docking and undocking, it does take time. So the overall duration of the surgery, of robotic surgery, could be higher than laparoscopic surgery. Still, there is a learning curve. And again, since the robo is quite big with multiple arms, they do have limitation as to how small children can be done. So it is technically more challenging to do it in children less than 5 kilos. So for surgeons, they say that the learning curve is 15 cases, but in anesthetic perspective, I think you do only 2 or 3 cases, then you get to know what's different with robotic surgery. Anesthesia-wise, it's very similar to laparoscopy, but the thing is, access to the patient is quite limited. So you make sure that everything is well connected, well secured, well taped. You have at least 2 IV lines with extensions to give drugs, and if required, we need to use second IV line. And instead of bolusing, we try and use articular infusion. So that's a closer picture showing the child lying there, and that's the robotic arms. In this situation, you can see 3 arms there. So you can see that the patient is completely covered by the robotic arms. So in an emergency, it's very difficult to access the patient. So just be more vigilant, anticipate things, and know what the surgical steps are, and be in constant communication with the surgeon, and keep watching the screen as to what's happening inside the abdomen. Yeah, so access to the patient is difficult. You need longer circuits, longer extension tubings like in a neurosurgery. In an emergency, undocking takes time. Okay, undocking takes time. So so just be aware of that. So there is a child positioned for a robotic pyeloplasty in the edge of the table. And that's the robotic arms before it's being docked on the patient. So you can see 1, 2, 3, and the 1 arm is not being used. So the 4 arms are here. Yeah, the robotic arms are quite huge, but make sure they don't sort of touch the patient or they are in contact with the patient, because it can cause pressure sores and so on. So in summary, laparoscopic and thoracoscopic surgeries, they do come with a unique set of challenges in small children. Smaller child, higher the risk of complications. So be aware of the surgeon's setting in terms of abdominal pressure, the CO2 flow which is being used, and observe the various steps of surgery, particularly the insertion of the Veress needle or insufflation of the gas into the abdomen. Thoracoscopy can be more challenging. You need to look at the ventilatory parameters you've set. You might need some tweaks in your ventilation, either increase in PEEP, increase in FiO2, increase in minute ventilation, adjustments to the tube. Okay, and finally, robotic surgery does have some implications, particularly access to the patient can be really challenging. Thanks very much. We're open for discussion now.
You can stop sharing your screen, Sanjay. Yeah.
Yeah.
Well, there's a few questions here. Thank you, Sanjay. That was a great talk. Yeah, I find that empyema, VATS, or even for chest drain placement in pediatric practice is one of the most challenging, nerve-wracking things. The kids are teetering on respiratory failure, unintubated, and then you give any little sedation, then you're pushing them into that, and then you add the element of pain and sedation. Dr. Paliwal has asked, is regional totally contraindicated for lap surgeries in children? Is capnothorax always necessary for thoracoscopies in children?
Yeah, so regional is definitely not contraindicated. I use laparoscopic. I use regional for all my laparoscopies. So for abdomen, I tend to use a rectus sheath block and a tap block. And in very small children, we can also give a caudal, a high dose caudal, which can cover the laparoscopic surgery. For thoracoscopic surgeries, depending on the surgery, I tend to give them a paravertebral block. So yes, I'm very pro-regional, so I do a block where possible. Is capnothorax always necessary for thoracoscopics in children? Yeah, I think it depends on the surgeon you work with. Compared to an open surgery, thoracoscopic surgery is much better in terms of pain control. So thoracotomy is so much more painful. So that's one reason why the surgeons tend to go for laparoscopic surgery. So they can do with a low pressure insufflation technique. So and the fact that we cannot do a one lung ventilation with a double lumen tube, because we don't have double lumen tubes less than 8 or 9 years of age. So yeah, low dose pressure is what we use for thoracoscopies.
I think Dr. Paliwal might be alluding you towards use of spinal anesthesia for.
Oh, okay, segmental spinal. Okay.
Or other region, yeah.
Yeah. And Dr. Vidya has posted, in the absence of pressure control volume guaranteed mode, we need to constantly watch the pressure. Volume control mode, and watch the volume and pressure control mode. Excellent. That's very true. What is the explanation for your first case scenario? Your hernia patient, I think, is right.
Yeah, I mean, the commonest thing is hernia. They give a they gas insufflation. They give a head down position. So if the patient is, if the tube is sitting sort of very close to the carina, when they give the insufflation, the diaphragm tends to get pushed up. So commonest reason I see is endobronchial intubation.
Endobronchial.
Yeah.
Yeah. Yes.
Yes, sure.
Yeah. So it's basically when you have patients sit down, it can happen not only in kids, it can happen in adults as well. Because you have paralyzed the diaphragm and the pressure of the abdominal content. So it's not only the pneumoperitoneum which is actually causing the diaphragm to act. So you can actually move the lungs, so whole thing is moving. The tube is stable, it's stuck, but the lungs are moving it. So you get endobronchial intubation. Even in adults, you can get when you're, like I said, it's closer to the carina.
Yeah, that's one reason. The other reason I find is, let's say someone ventilates the patient with pressure control ventilation. and continues with pressure control ventilation with introduction of pneumoperitoneum. So what happens is your tidal volume slowly tends to come down, and we have not realized it. So so basically, you're causing a hyperventilation. So the basal region starts collapsing. So slowly, you can see the oxygen slowly started coming down. So when you're using a volume control, pressure control ventilation, as you've quite rightly mentioned, Vidya madam, so you need to look at the volume. If the volume is coming down, some people swap to volume control ventilation or go for a pressure control volume guarantee.
So what is your threshold for permissive hypercapnia in these patients? How high do you let the carbon dioxide climb?
Okay, so yeah. So I was expecting this question from someone. So normally I have a cap of around 60, 65. Okay. Unless the child has got some intracranial issues. But I'm not too bothered about high CO2s because you can get it down eventually, unless they have any intracranial issues or any cardiac issues, which makes them prone for arrhythmias. So yeah, I don't aggressively try and bring the CO2 down by increasing the ventilatory parameters.
Okay.
What do others feel? JD, Senthil, you can say what is your threshold?
She was answering.
I don't know why people fear carbon dioxide so much.
We have this terminology called permissive hypercapnia.
Intraperitoneal carbon dioxide actually is considered to be useful even in prevention of sepsis. And I think it's an inflammation. So CO2 is not bad, at least for that. Rather, there were papers in which they had thought about actually using intraperitoneal CO2 in intensive care. So I think people should be worried about oxygen more than carbon dioxide. But actually, obviously, at a certain extent, you do actually see patients sweating. Yeah, UCD,
you have acidosis and its effect on the myocardium or on the pulmonary hypertension patients, where it can contribute to higher pressures. I think I was recently I was in a pediatric conference here in Vancouver, where they were presenting how they do their laparoscopic inguinal hernia repairs in ex-preterm babies by using a caudal as a primary anesthetic technique without intubating the airway, which I thought it was bold for a Western world to do, but there is some push towards, it all stems from the fact of avoiding general anesthetic as well as avoiding intubation in an ex-prum baby who may have like subglottic stenosis and respiratory distress syndrome and bronchopulmonary dysplasia. And they're exploring those options of they were successfully doing in some of these patients. And I guess they were sedating some of these kids using either, I'm thinking either ketamine or dexmedetomidine as some degree of sedation to administer the caudal and just doing it without any intubation. And that answers Dr. Paliwal's question about regional and laparoscopic surgeries in children. Yes, it can be done.
I think
it's being done.
Jody, I think Rajesh Shah again actually said that he's done few laparoscopics in pediatric with spinal till at the age of 5 months.
Yeah.
So I think, I don't know whether these are premature kids they use or.
Yeah. Very often the challenge is with the spinal is that you need to have a very efficient surgeon, and unfortunately some of these preterm kids will have the inguinal hernia is not like 15-20 minutes procedure. It turns out to be they are very adherent, and they have to explore quite a bit, and there's a big chance of running out of time, and the spinal has started to wear off because they didn't last too long, 45 minutes to an hour, that's the max you get. And if you have bilateral hernia repair, we can get into a situation where you're giving increasing amount of sedation to keep the child still.
That's why in some situations, what we do is if there's a bilateral hernia in a very small child, we combine spinal and a caudal. Quick onset, and the caudal tends to work for a longer time.
Yeah.
Dr. Vidya has asked about ABG in robotic surgery. No, madam, we don't sort of routinely do ABGs in robotic surgery unless there is a complication or there's a major concern about the hemodynamics or respiratory parameters. And how superior is lap hernia compared to open in small children? I think
that's a surgical question,
but
it's, I
yeah.
think I think it has been disproven, I would say. I'm not quite sure. We went through the phase of doing everything laparoscopic, lap hernias, and then now most of surgeons has given up and they just do the usual routine way. But still, one or two surgeons still do lap hernias. But in terms of the timeline, yes, it involves where I would have put in a caudal, and now I have to change my anesthetic techniques. Where I would not have intubated, now I have to intubate. It changes the anesthetic technique if they choose to do laparoscopic hernia. But in terms of the time-wise, it feels they're still quicker. I mean, equally quicker. They just get in, 2 stitches on each of the groin, and come out, and they're fine.
So clearly, one thing for sure, ma'am, is the pain is lesser with laparoscopy compared to open, particularly with bilateral hernia.
Yeah, but I think with the bilateral hernias, laparoscopy definitely holds some advantage.
DexCat works nice for preterm babies along with the regional. Very true. Incidentally, yesterday I was doing it's only a PICC line exchange, PICC, peripherally inserted catheter exchange, on this 6-month-old child who is, I think this child is waiting for a liver transplant, is post-Kasai, failed. My dexketamine anesthetic did not work for that one. He decided to leave the table and walk away. No, I'm saying, what dexmedetomidine dose we used, half a mic per kilo followed by another half a mic per kilo. Ketamine dose was 1 milligram per kilo followed by another milligram per kilo. And then I had to supplement with propofol, pretty much like an infusion for the next 15-20 minutes. And then we also look at, okay, if I'm given a mic per kilo of dexmedetomidine and 2 milligram per kilo of ketamine, that's like good general anesthetic doses. And this kid is going to be in the recovery room for a longer period of time. So sometimes we fall back to, okay, the propofol, add a little bit of a mic per kilo of fentanyl, and you can equally safely get this procedure done. And the recovery is probably quicker. That's a field. Again, obviously that DexCat has the advantage of having a patent airway without much intervention needed. Yes, sure.
I mean, for like change of PICC line and things like these are not, I wouldn't say that they are very painful procedure where you would want to use something like ketamine and dexmedetomidine, which are, okay, they are sedatives, but they have got strong analgesic properties as well. Yeah. Whereas propofol, I think a lot of times propofol does the trick. What you can give local infiltration and the skin side, but otherwise, I mean, the whole procedure, these are not very painful procedures. So why would you want to use DexCat? I think idea is to keep the patient asleep. And I think use as an infusion or a PCI in kids and adults. I think does the work. Propofol does the work. There was actually, there are 2 questions, which one was from Ko Heymin, say asking about compared to ESP and thoracic epidural in thoracic surgeries. I think they were trying to actually ask what is the difference between the erectospinal block and thoracic epidural in thoracic surgery. Thoracic surgery on the epidurals, the gold standards yet?
It will always be the gold standard. Yeah.
And then I think Ankit had asked, he had made a comment or asked a question. Okay, yeah. What regional anesthesia do you give for VATS decortication? We have shifted from epidural to erectospinal. For erectospinal, very unreliable. So now doing ultrasound guided paravertebral, what protocol do you follow?
I do exactly the same. I use ultrasound guided paravertebral block. It's a single shot technique.
Senthil?
I personally use ultrasound guided erectospinal blocks.
So it works for you, Senthil.
It does work for me. Yeah.
Yeah. I think erectus spinae can be. I don't know about pediatrics, but adults, I find people still struggle. I think that's because they're not in the right plane.
Because I find the ultrasound-guided paravertebral block, if you can see the pleura being pushed down as you inject the drug, that's a fairly good indicator you're in the correct place. And generally, when you do that, it works. Whereas erectus spinae, I think it's sort of between two fascia. So I think they probably more skill in doing erectus spinae than a paravertebral. That's my understanding or feeling.
Yeah, and I don't understand why you can't do a paravertebral when the lungs is going to be open. So what is your worry?
It's a question.
Why? I mean, erectus spinae block is just a poor man's. I would say a poor man's paravertebral block.
Yeah.
And people do it because either they're not skilled enough to actually get to the paravertebral space, or they're afraid of causing a pneumothorax. But here, when doing decortication, you are going to have the open lung, and they're going to be chest drained. So what's the worry? Why not use which is actually a standard?
The only limitation of paravertebral in a VAT procedure is sometimes when the pleura is thick or it's not moving, you will not see a pleura. So that's where the plane, you're not sure where you're injecting the drug. So that's a limitation of using paravertebral.
So I would say the same thing with that. How are you going to get a spread from erectus spinae when you say that the local anesthetic seeps through the costotransverse foramen to actually give you paravertebral block? So you think the spread will be better in there, or we don't know. So I think
the bottom line will be choose your technique, what you're comfortable with and what you're familiar with. It'll come down to, again, in the pediatric practice, institutional practices, the number of times in a big institutions where people get to practice this on a regular basis gets very less, especially when you have trainees floating around and they want to have a hand on these cases. We don't have high volumes on, and very often in pediatrics, the number of thoracic surgeries is extremely small. It's not that common where you can have a reasonable volume of paravertebral single shots or catheters to keep your skills. That's one of the challenges we have here.
I think Ankit also had. Ankit Desai is a pediatric anesthetist from Mumbai. They run a very good pediatric anesthesia service. So he's also, I think, said that lap hernia more commonly done if presentation is unilateral, and they have to rule out hernia on the other side. So more for diagnosis of the other side as well. So that's what. So both can be done, as you say. And Rajesh has said that DexCat 1:1 per kg is good dose. I think he means is that using 1 mic per kg of dexmedetomidine along with 1 milligram per kg of ketamine. Is that what he's talking about? 1:1.
Yes.
So
that's what I use. Dr. Paliwal may have different ratio. Dr. Paliwal has asked, read about epipleural block. I have never heard about it. I'm sorry.
Probably you can elaborate, sir, Dr. Naresh. Never heard about it.
Dr. Paliwal, you can unmute yourself and you can come in.
Hello.
Yes,
just today only I read about epipleural block. That is actually the surgeons place a catheter for the pleural space, and they use it as a paravertebral block. So today only I read about it. So is it possible in the VATS procedures, the surgeons can give local over the pleural space? Actually, pleural block is known. Whenever you get an accidental this puncture in the pleura, you can put a local anesthetic. The pleural block can work. That is a known technique. But epipleural block, today only I read about it. They put a catheter while doing a surgery.
I don't know about the pediatrics, but I know in adults what they do is that you can actually see that you can put a catheter. So the anesthetist puts a catheter, and the surgeons can see if the patient is on the side. So they can actually see the, epidural, the catheter being put with, I don't know, dye or whatever, and they can actually see that
it is under vision. They put a
it's
catheter.
in position. Yeah, it's in per.
That is
But-
epipleural
So
block.
does it mean that the catheter is above the parietal pleura?
Above the pleura. Yeah, above the
parietal
pleura. That
pleura.
is,
Okay.
I think it's
epipleural.
similar to what you surgically inserted tap catheters would be.
It's
In terms of
almost
the-
similar.
Yeah.
It is
The question
very
is
commonly
whether
done
there would
under-
be adequate spread
Mm.
in the context of you're talking about VATS decortication. Are we expecting the parietal pleura to be as free as in a regular patient, or whether you would expect any adhesions in that layer? I'm not sure.
Ankit has again actually pointed out that in VAD surgery, the decortication, that is, they actually remove the parietal pleura. So where are you going to actually have the catheter?
Okay, that is.
So that's why I say I think the paravertebral space, putting a catheter in paravertebral space, which is looking at that. Okay, you may not be able to see the pleura being pushed down, but if you are actually know that you've gone through the costotransverse ligament, then you are probably there. But what we don't know is how the spread is going to be. I think we don't know how extensive the spread will be. And in the kids, the tissues they tend to have a better spread than in adults. But
Yeah.
no. Has anybody looked into it and seen Senthil?
I mean, I haven't done extrapleural, epipleural.
No,
blocks.
just I mean, looking at
No,
the
I'm
spread
not sure of any
cholestatic.
literature on that.
Maybe that may be the reason why people are still for thoracic epidural for these cases. I mean,
yeah, I mean, for me, from our institution, the challenge is maintaining the skill set with adequate volume. That is our primary reason why we are little hesitant to explore newer option, is that we don't have adequate volume to maintain our clinical practice.
I mean, even in the best of the hands, it's said that with thoracic epidurals, the failure rate can be as high as 25%. But if it works like beauty, isn't it? It is the gold standard.
In fact, our thoracic epidural rate has come down significantly with the institution of chest wall blocks, serratus and PECs and paravertebrals. So increasingly less and less of chest wall block. Even for caudals also increasingly disappearing, because we tend to do linguinal blocks, parental blocks, or penile blocks. And so those populations which traditionally would have got a caudal block are moving towards peripheral block. So the neuraxial block is, it's on the decline, definitely.
Yeah, that's from the two papers they published, isn't it? From France and the Plan Network as well, showing that the complication rate is 6 times higher with the neuraxial blocks compared to peripheral nerve blocks.
And that becomes a vicious cycle. You haven't done one for ages. Now you don't want to try after quite a while. Yeah. That comes to the neonatal thoracic epidural as well, like where we would have like TEFs and straightforward, likely I'm not going to be ventilated for long. We might have either caudally thread a catheter or a direct thoracic epidural. Direct thoracic epidural, extremely rare these days. I haven't seen one for 4 or 5 years, a direct thoracic epidural in a neonate. All right. I think that's, is there any more questions in the YouTube? Sure.
No, I think
Okay.
everybody says a great session.
Excellent.
I think it's been absolutely wonderful.
Yeah, excellent. Thank you. Thanks, Senthil. Thanks, Sanjay. And thanks
Thanks for everyone. Yeah.
And the faculties who joined us on the Zoom. And
YouTube as well.
as always, making it possible for us to conduct these sessions.
Mm.
We'll catch up with our next one, hopefully in the month of January.
Thank you, guys.
Thank you.
Yeah.
Bye-bye.
Thank you. Thank you. Bye.
Bye.
Take care.
Have a good weekend. Bye-bye. And Happy New Year to all.
Happy New Year.
Yeah. Happy New
Merry
Year. Bye.
Christmas and Happy New
Merry
Year.
Christmas.